are you everyone? This is Jae-eun Jung from Seoul National University Gwanak Dental Hospital. I work at the Department of Periodontology. Today, I will talk about the basic surgical skill, incision and suture methods for improving your surgical skills. Sometimes we expect secondary healing on purpose like APF to increase the width of gingiva. You can see the picture in the left side. But mostly we expect primary intention healing because it is key point of successful regeneration surgery and the patient will have less discomfort and healing will be faster. To accomplish the primary intentional healing, wound closure is most important. We have to achieve the passive flap adaptation by flap advancement technique. Periodontal releasing incision can make flap advanced passively. And we should avoid excessive compromise of the vascular support and integrity of the mucogingival flap, because blood supply is an also key factor for wound healing. So like in the right side case, I did a GBR with the Gore-Tex membrane, advanced the flap with vertical and periosteal releasing incision, but the non-resorbable membrane may inhibit the blood supply, so after the stitch out, the wound dehiscence occurred. First step to obtain the favorable healing is to design a flap. Good flap design can obtain a good visibility. And do not compromise the flap supply or aesthetics, especially in the interdental papilla area. The incision line should not be designed in a direction transverse to the direction of blood vessel. And good flap design also allows the passive adaptation of flaps. Finally, incision line cannot be designed over the bony defect because it is hard to reflect the flap cleanly because of the granulation tissue filling the defect. Let's check the principle when we do the incision. The incision is made within the keratinized gingiva to avoid excessive bleeding and easy handling of soft tissue. The incision should be made at right angle to the underlying bone, and the blade should move in single, constant, firm movement. The incision is made all the way to the periosteum at a time so that the flap should not be damaged during the dissection or retraction. To make incision, there are some kinds of blades. From the left, number 11, number 12, number 12B or D, number 15, and number 15C. And in periodontal or implant surgery, we usually use the number 12 blade or number 15 or number 15C blade. This is number 12 blade. Number 12 blade is very useful to make incision in edentulous ridge from distal to mesial. Keep contact the blade tip to the bone surface and move from the distal to mesial and continue to the circular incision. This is the key point. Move the 12 blade from distal to mesial. Next, number 15 or 15C blade. Number 15 blade is the most widely used one, but look at this figure close. Number 15 blade cannot reach the distal surface of the tooth. So use the number 15 blade first from the distal of the edentulous ridge, and then use number 12 blade at the distal side of the tooth. Number 15 blade is very useful, but sometimes number 15 blade cannot follow the irregularities of the alveolar bone, so undissected periosteum can be remained. If there are undissected periosteum, the flap retraction will be very difficult, and the crushed wound is made. When you use number 15 blade, make the blade handle steep to the bone surface, not to remain the undissected periosteum. In number 12 blade, the force is focused on just one point, the tip of the blade. The movement of the blade is not smooth, so apply the light pressure. Please use both number 12 and 15 blade properly together. And when you use number 15 blade, the blade is located like this. So there is undissected periosteum. just under the end of the incision line. So at the point where the two incision lines meet, we have to make the incision line slightly overlapped like this. Let's take a look about horizontal incision. Horizontal incision should be placed in keratinized gingiva. This is the number one principle. If incision is in keratinized gingiva, there will be less bleeding, easy approximation of the flap and suturing, and fast healing and less postoperative pain. Horizontal incision should be made in keratinized gingiva. Horizontal incision in the alveolar mucosa will show much bleeding. Check this blood vessel distribution of the gingiva on the right side, and it will show the delayed healing, postoperative swelling, and pain increase. Usually, in maxillary area, slightly palatally positioned horizontal incision is favorable, and this palatally positioned incision line can be a reference line for an implant position. And the operator doesn't need to retract the thick palatal flap to get the enough visibility. In mandibular area, crestal incision is favorable to maintain the keratinized gingiva at lingual side. If the horizontal incision is located on the buccal side, the postoperative bleeding or swelling will increase. Unlike maxilla, mandibular lingual flap is easily detached from the bone and the retraction is easy too. In maxilla, be careful to recognize the ideal alveolar crest before the bone resorption occurred. After teeth loss, alveolar bone resorption takes place from buccal side, so the alveolar crest can be located palatally. In mandible, you can use the retromolar pad as a reference point because retromolar pad is maintained after tooth loss. But in maxilla, maxillary tuberosity can be resolved after tooth loss, so it is difficult to imagine the ideal alveolar crest. So if you make palatal subcrestal incision and place the implant at the palatal incision line, the implant will be located too palatally. Check the ideal alveolar crest according to the mandibular teeth and place the implant slightly buccal side according to the palatally located incision line. In mandible, when you make horizontal incision, usually crestal incision is used. Crestal incision can maintain keratinized gingiva in lingual flap, and lingual flap is thinner than maxillary palatal flap. It is easy to retract lingual flap. So you don't have to retract lingual flap. You can get enough visibility by dissection of the lingual flap. The horizontal incision in mandible follows the central groove of the adjacent tooth or halfway of the retromolar pad. After you make incision, we dissect the periosteum. There are some kinds of instruments for dissection and retraction of the flap. Number 9 molt, also called periosteal elevator, and P24G periosteal elevator are commonly used in periodontal implant surgery. In P24G periosteal elevator, the sharp side is for dissection of the periosteum, and round side is for retraction of flap during surgery. It is very important to keep the wound clean. It means that clean and sharp incision line dissect and retract the flap automatically. Blunt dissection causes postoperative pain, swelling, and delayed healing. Crush wound like right side photo will show delayed healing. To avoid blunt dissection, cut the periosteum with Gracie curette or other sharp instruments after when you do use the blade. After incision and retraction, I usually use tagging suture to retract the flap. If you secure the buccal flap to the buccal mucosa, you don't need to retract the buccal flap with periosteal elevator. Then the assistant retract the buccal cheek with dental mirror. You can get adequate visibility in surgical field. When we decide to the flap design, we should consider the blood vessels. In maxillary area, anterior buccal parts gets blood from facial artery and infraorbital artery. So when you make a flap design in maxillary area, especially maxillary buccal area, please confirm the infraorbital artery. The infraorbital artery passes like this. So if we cut the blood vessels transversely, for example in semilunar coronally positioned flap surgery, there would be a scar because of the blood supply was cut. Check this picture with the scar after healing. The simple incision line is the best. Crestal incision is not enough to open the flap and secure the operation site. Circular incision is easier to suture than the vertical incision, but circular incision only gives the limited mobility of the flap and limited visibility too. So if the bone graft is accompanied by the implant procedure, circular incision is not suitable. In maxillary anterior area, we can modify the circular incision to preserve the interdental papilla like here. In this figure, then the problem like black triangle will be minimal. There are three kinds of incision method around the teeth. The red line is the incision when we do the ENAP. The red line removes the inner surface of the periodontal pocket and reach the root surface. And second, blue line is the conventional circular incision that starts from the marginal gingiva to the alveolar crest. And the green line is the incision line used in modified Wiedemann flap. It is consisted of 0.5 mm to 1 mm submarginal incision head to the alveolar crest. The incision around the teeth are more difficult than in edentulous ridge because there are a variety of group of dentoalveolar, dentogingival dense collagen fibers around the teeth. Vertical incision is able to localize the surgical field and mobilize the flap, but it is more difficult to suture and postoperative pain can be increased. Vertical incision is possible to get scar tissue, so don't put the vertical incision at mid-crest. Vertical incision can be made at mesial line angle, distal of the adjacent tooth, and distal line angle of second next tooth. Vertical incision at distal of the adjacent tooth is the commonly used one. First, suture the crestal incision and the vertical incision with a simple interrupted suture or anchor suture. It is easier to reposition the flap around the vertical incision. But in the case of GBR, the incision line should be placed 4 or 5 mm apart from the bone graft site, so you have to choose the third one design, and suture must be done at the interdental papilla first in this case. In many cases of implant surgery, the regeneration technique such as GBR is accompanied by the implant placement. So for successful GBR, primary closure is most important. And for primary closure, we have to advance the flap coronally. How can you achieve the flap lengthening? Flap can advance about 1 mm by 1 vertical incision and 2 mm by 2 vertical incisions, and 5 mm by periosteal releasing incision. So periosteal releasing incision is most efficient method for flap lengthening. Periosteal releasing incision should be toward outside with a new blade. To make the incision toward outside, you have to pull the flap outward and then make the releasing. The adequate depth of the periosteal incision is 0.5 mm. If it is too deep, many blood vessels are damaged and postoperative bleeding and swelling will increase. So as we have seen before, the tension-free suture of the flap in periodontal or implant surgery is very important factor in wound healing. The main purpose of suture is passive adaptation of the flap margin and mechanical stability of the flap for wound stabilization. There are 3 patterns to position the flap margin: everting, inverting, and oppositional. But in periodontal or implant surgery, everting suture patterns are used because the implant areas often require dispersal of tension forces along the wound closure line. The aim of suture are wound closure, hemostasis, maintain the blood clot, adaptation of flap to bone or root surface, and fixation of the graft or membrane, and secure the visibility. There are 4 essentials for suture: needle holder and tissue forceps, suture materials, and scissors, that the tip of the scissor is slightly curved. Now let's review the suture material. There are observable and non-observable suture materials, and also braided and monofilament materials. How do we choose the suture materials? Because the purpose of suture is to maintain the structural integrity during the wound healing, the suture materials should be maintained longer in root surface than alveolar bone, because there are differences of the blood supply. And if you want to maintain the suture material longer, monofilament suture materials are better, because much plaque can attach to the braided suture materials. Every suture material reveals the information of the needle on its cover. 12 to 30 mm of needle length is suitable for mucogingival surgery, and longer needle, 17 to 18 mm, is suitable for periodontal flap surgery. Cutting edge can be tapered, reverse cutting, and round. Reverse cutting edge has high efficiency. That means it can pass the flap easily, and it does not make flap tearing when we pull the suture make the knot. And needle diameter is matched the suture size to minimize the tissue damage. Choosing finer suture diameter may reduce the trauma on the tissue, but the difficulty of the skill may increase. The silk is from natural, non-absorbable, and braided material. We usually use silk in the extraction socket. The silk is strong, easy to make knot, and cost-effective. But the plaque can attach the silk very easily, so the tissue reaction is quite bad. Nylon is most widely used in periodontal and implant surgery. It's a synthetic, non-absorbable, and monofilament suture material. The plaque cannot adhere to nylon, so the tissue reaction is good around the nylon. And the tension and tissue penetration ability are advantage of nylon. But nylon is quite hard to make knot and more expensive than silk. Another commonly used suture material is Vicryl. It's a synthetic polygalactin absorbable material. The coated Vicryl is maintained more than 3 or 4 weeks, but uncoated one will be absorbed in 2 or 3 weeks in the oral cavity. EPTFE suture, also called Gore-Tex suture, can be used in membrane suture. Like in this picture, Gore-Tex suture material is expensive but has very good tissue reaction, so I sometimes use this when I need to suture the barrier membrane underneath the flap. I usually use 5-0-ethylene for the implant surgery or periodontal surgery. This is monofilament non-resorbable suture materials and has excellent strength and less tissue reactivity. These kinds of monofilament suture, like nylon, ethylene, Deflon, are more difficult to handle or make tie. Because there is little friction in the suture material, 4-0 nylon suture can irritate or abrade the oral mucosa around the wound site, so I recommend to 5-0 nylon or ethylene suture. So how we make perfect suture? These are main principles. Pierce the flap surface with the needle perpendicular to the flap, and the piercing the point should be located 5 mm away from the flap margin. The suture should go from movable tissue to non-movable tissue, and do not touch the alveolar bone or tooth surface to prevent the needle bend. Surgeon's knot is a commonly used method for making knot. This knot does not easily break and well maintained even with monofilament suture material. Surgeon's knot is formed by 2 throws of suture around the needle holder and the first tie and 1 throw opposite direction in the second tie. The knot should not be placed at the insertion point and incision line either. The choice of knot depends on the suture material. For example, if you use nylon, you'd better choose surgeon's knot. And excessive tension should not be applied. The simple interrupted stitch is a suture technique used to close the wound. It is the most commonly used technique. Placing and tying each stitch individually is time-consuming, but this technique keeps the wound together even if one suture fails. It is simple and easy technique. Let's look at the simple interrupted suture and the surgeon's knot. The needle should pierce the flap with right angle. Buccal flap first, and then go to the lingual flap. And this is how to make surgeon's knot. 2 throws of suture around the needle holder on the first tie, and 1 throw opposite direction in the second tie. And then cut the suture material. Anchoring suture uses the tooth, implant, masticatory mucosa, or connective tissue of the vestibules like an anchor. Needle placed at the lingual area of the flap adjacent tooth. Anchored around the tooth passed beneath the opposite flap and tied. It is useful to close a flap mesial or distal to a tooth. For example, distal wedge procedure. And close the facial and lingual flaps and adapt them tightly. This is anchoring suture and it is useful in distal wedge procedures. Pierce the buccal flap first, and the suture material should go around the adjacent tooth to make an anchor. And then pierce the lingual flap again. Then we can achieve the anchor at the adjacent tooth and make a knot. You can push the flap to the anchor side. Next is continuous suture. The main advantage of the continuous suture is the speed, because we just make 1 tie in the long wound area. But main disadvantage is that if the suture breaks in one point, the flap may become loose or the suture may untie from multiple teeth. The continuous sling suture is used to adapt the buccal and lingual flaps without tying the buccal flap to the lingual flap. The teeth are used to suspend each flap against the bone. Continuous locked suture make wound margin approximation with successive loops. The advantage of continuous locked suture is useful for long edentulous area, and it has the advantage of avoiding multiple knots. There are friction points, it means locks along the suture, to reduce the tendency of suture loosen when placing the rest of the suture. Thus, the locked stitch help to hold the previously placed portions of the continuous suture tight. Unlike continuous suture, if one suture breaks or fails, the flap may keep the position during healing because of the locks. Matrix suture is a special type of suture and is described as horizontal and vertical. Its indication in cases where strong and secure reapproximation of wound margin is required. They also allow for good papillary stabilization and placement. This is vertical matrix suture. I usually use this suture technique when GBR is done because this technique can help everting the flap margin. This is how we do the vertical matrix suture. The needle passes at two levels, one deep to provide support of the wound surface at a depth, and one superficial to draw the edges together and evert them. Needle passed from one edge to the other and again from lateral edge to the first and not tied. When needle is brought back from the second flap to the first, depth of penetration is more superficial. So just remember the far, far, near, near, and tie. This is how we perform the vertical matrix suture. It is very useful in GBR area. First point is at deep level of the buccal flap. And second point is a deep level of the lingual flap. And then third point is a superficial level of the lingual flap. You have to place the third and the last insertion point close to the incision margin. And the last point is a superficial level of the buccal flap. And make tie at the buccal side of your flap. Check the gingival margin everting. These are the examples of vertical matrix suture. Look at the first case. After a large amount of bone graft, barrier membrane was applied. Check these two vertical matrix suture. After that, the flap was everted and add some simple interrupted sutures. Look at the good adaptation of the flap without tension. And this is the second case at the low column. After GBR and membrane application, also the two vertical matrix sutures were done, and additional simple interrupted sutures were made. The flap adaptation was very excellent. Horizontal matrix suture is the strongest type of suture. This is used in large distances between the tissues, closure of the bone graft in implant sites. This can evert the much amount of flap in surgical area, but sometimes the depth of the vestibule can be very shallow. But this suture can leave a gap between flaps, so you have to add some simple interrupted suture along the flap margin. Horizontal matrix suture can be used for membrane stabilization and reduce the dead space. Insert a needle from the lingual flap. And then you have to do the periosteal suture, inner surface of the buccal flap. Pull the buccal flap outward and insert the needle at the periosteum. And then pierce the lingual flap again. Horizontal matrix suture can be used for membrane stabilization and reduce the dead space. It is very useful for membrane fixation. In this case, we make a knot on the lingual side, but you can do the vice versa. You can make knot on the buccal side too. If we see under the flap, the suture can push the membrane into the bone side. Personally, I usually apply the horizontal matrix suture to secure the barrier membrane for GBR under the flap every time I do the GBR. This suture can press the membrane that covers the grafted bone, so it can eliminate the dead space between the graft and membrane or underlying bone and graft materials. Figure of 8 suture pattern goes like this. This is usually used for extraction socket closure and also used for adaptation of gingiva papilla around the tooth and socket preservation technique. This suture induces rapid closure of the wound, but due to its orientation and direction, it is difficult to remove and it leaves a significant amount of suture thread inside the socket. And the other drawback of the figure of 8 suture is that this suture pulls the buccal and lingual side of flap too tightly. So after completion of the healing, the extraction site can shrink a lot. So to prevent this shrinkage, this is hidden X suture proposed by Dr. Park Jung-chul in Kyung-hee University. This is conventional figure of 8 suture on the first one. The needle passes through over the extraction socket twice as if forming a continuous suture. A large crossed X is created over the socket after suturing. The blue arrows indicate the pulling vectors created by the X suture. Hidden X suture, the needle enters the buccal flap and passes to the opposite side in a diagonal direction. Then it passes again from the buccal to lingual side, also in a diagonal direction. A crossed X is created under the flap, unlike the X suture or crisscross suture. The blue arrows indicate the vectors created by the hidden X suture. These are the healing of the hidden X suture and X suture. In hidden X suture site, there is a minimum tension along the buccal lingual axis, so there is a reduced loss of keratinized gingiva. And it can hold the graft or membrane in the extraction socket well. So this suture technique is very useful to do in the socket preservation cases. Suture removal is also important. Sutures should be removed using aseptic and stirrer technique. Step 1. Cleanse the area with an antiseptic such as hydrogen peroxide, chlorhexidine, or povidone. And step 2. Pick up one end of the suture with forceps and cut as close to the flap as possible where the suture enters the flap. And step 3. Gently pull the suture strand out through the side opposite the knot. The suture should be removed without pulling any portion that has been outside the flap back through the flap. At last, I want to introduce the new periodontal mucoadhesive dressing, Ora-Aid. A new mucoadhesive periodontal dressing called Ora-Aid was developed. Ora-Aid is a dressing system comprising a mucoadhesive layer and backing layer and provided attached to a thin film. The protection side is an outer surface of the dressing and to protect the wound area from the outside for 12 hours of contact duration. The attachment side is an inner surface that attaches to the gingiva. This part is attached to the wound for 12 hours of contact duration. The Ora-Aid in extraction socket is very useful. The purpose of the Ora-Aid in extraction socket is to stabilize the blood clot or graft material when socket preservation procedure is performed. Socket preservation is widely used procedure to prevent the ridge volume shrinkage after removal of tooth. In these days, we usually use open membrane technique and expect secondary healing over the grafted material. Excessive pulling of the buccal flap makes the vestibule shallow, so open membrane technique is more preferable. Ora-Aid, the mucoadhesive dressing, is easily used in these cases. After extraction, Ora-Aid over the grafted material and collagen membrane helps keeping the graft material stabilization. The Ora-Aid in extraction socket can be maintained well in position, but if you need to secure the Ora-Aid more firmly, suture can be used. In extraction site, after placement of bone graft, apply the Ora-Aid to the socket. Horizontal cross matrix suture, like this, can push the Ora-Aid toward the extraction socket and help the dressing stay in position. You don't have to suture the dressing directly. Horizontal matrix suture around the socket at the oral mucosa will be enough. And finally, I will show you the video how we use the Ora-Aid in extraction socket. First, remove the mandibular first molar by dissection the tooth. Remove each root first. And then trim the template first, according to the size of the extraction site. And check the trimmed template at the wound site. And then, for socket preservation, place the bone graft into the extraction socket. And pressure the socket site to remove the excessive blood or excessive graft material. And trim the Ora-Aid according to the template before we made. And remove the film and place the Ora-Aid to the extraction site. This is enough, but if you want to secure the Ora-Aid more firmly, we can do the horizontal cross matrix suture. Horizontal matrix suture can be used to secure the mucoadhesive dressing. You don't have to suture the dressing directly, just to suture the oral mucosa around the dressing. I really hope that the fundamental surgical skills discussed today are very helpful in your daily practice. And if you have any questions or comments, please contact me at this email. Thank you for your attention.